I'll request Dr. Debasis Chakrabarti to start his talk. He will be talking on diagnostic evaluation in primary congenital glaucoma. Thank you, Debasis.
Good morning, everybody. Thank you, Dr. Mandal sir, for giving me this opportunity. So I'll be speaking on the diagnostic evaluation of primary congenital glaucoma. So to begin with, just a brief overview of primary congenital glaucoma. As we all know, it is the most common form of developmental glaucoma, and the basic etiology is isolated, non-syndromic maldevelopment of the trabecular meshwork with no other ocular anomaly to explain the high IOP. It's usually inherited in an autosomal recessive manner, but there are other modes of inheritance as well. Family history is seen in about 10 to 40% of cases. It is more common in consanguineous populations. Mutations in CYP1B1 gene have been reported, apart from other mutations as well. And the definitive treatment for this condition is surgery. So the classification according to the age of onset, it can be neonatal or newborn onset when it is within 0 to 1 month, infantile onset between 1 to 24 months, and late onset or late recognized when it is more than 2 years. And it is important to understand that more severe the angle anomaly, the earlier is the presentation and the worse is the prognosis. Hence, the condition should be detected at the earliest stage and appropriate surgery should be employed. Now, clinical evaluation is extremely important for this condition because number one, prompt diagnosis of childhood glaucoma and appropriate treatment can minimize the degree of visual impairment. And number two, there are certain mimickers of this condition, primary congenital glaucoma. We have to eliminate this at the outset, and some of these conditions can actually be life-threatening for the child. While speaking on the diagnosis of primary congenital glaucoma, like in adults, we have to rely on the IOP. In children, only IOP alone is not the main thing, because IOP measurements in infants and young children, especially during examination under anesthesia, can potentially be affected by many factors like the type of anesthetic used, the time point at which the IOP is recorded, and so on. So in children in particular, apart from the intraocular pressure, we have to look for other signs of glaucoma like ocular enlargement, the presence of Hobbs striae, the increase in the cup disc ratio, and so on. The aims of evaluation are to confirm the diagnosis, to discriminate between primary and secondary developmental glaucoma, establish baseline parameters, to assess the severity and prognosis, to rule out any other ocular and systemic comorbidities, and in particular to rule out space occupying lesions like retinoblastoma, which can sometimes mimic primary congenital glaucoma. So in the history, first of all, we have to document the age of onset of symptoms, the classical symptoms like epiphora, photophobia, and blepharospasm, and as well as corneal haze and opacification. Rarely red eye mimicking conjunctivitis, PCG can present in this way. We have to document family history like parental consanguinity, presence of glaucoma in the siblings, gestational history like rubella, and delivery history, example use of forceps, because there can be signs which can mimic primary congenital glaucoma in these situations. Coming to the symptoms, the classical symptoms described in most Western textbooks is a classical triad of epiphora, photophobia, and blepharospasm, which is attributable to the IOP-induced corneal epithelial edema. However, in the Indian subcontinent, large eyeball size and hazy eyes from corneal edema may be the more common presenting features, and a rare presentation can be acute corneal height drops. So the vision has to be assessed according to age-appropriate methods. The key to the diagnosis of primary congenital glaucoma is examination under anesthesia, and we have to record the refraction, corneal findings, intraocular pressure, gonioscopy, ophthalmoscopy, and take the decision for surgery. In many conditions, the surgery is done along with the EUA. These are the requisites for EUA. So you have to use a pediatric speculum, calipers, tonometers, ophthalmoscope, retinoscope, direct gonio lens, and imaging like the B-scan. So regarding the choice of anesthetic agents, as we have discussed, the IOP is largely affected by the anesthetic agent. The degree of IOP lowering is unpredictable and depends on the agent chosen, the route of administration, the depth of anesthesia, and the starting intraocular pressure. All anesthetics and sedative agents lower the intraocular pressure except ketamine, chloral hydrate, and benzodiazepines. Sevoflurane is the most commonly used inhaled agent due to its convenience and safety profile. And it is very important that the IOP should be recorded the moment the child stops moving after inhaled anesthesia and prior to intubation. Regarding the tonometer, Perkins is a gold standard. Tonopen is also used, but it overestimates the IOP compared to Perkins in normal children and in those with glaucoma. Eye care is portable. It has a similar reliability to Tonopen, but the advantage is that it does not need topical anesthesia and can be used in the upright position. It's important that we use the same instrument on follow-up, and again to stress that the IOP should be measured as soon as possible after initiation of the inhalational anesthesia and prior to intubation. The corneal haze is representative of the severity. The greater the haze, the greater is the severity of the glaucoma. It's usually more in center, and we have to document what are the structures that are visible, like the pupillary margin, iris details, and fundus details. Initially, this edema is simple epithelial edema due to elevated IOP. Subsequently, there is permanent stromal edema. That is why we have to act early. Untreated, the edema progresses to stromal scarring and irregular corneal astigmatism. The corneal diameter should be measured. So the corneal enlargement secondary to elevated IOP usually occurs before 3 years, and it's a marker to establish the diagnosis and progression. The differential diagnosis of increased corneal diameter are megalocornea, connective tissue disorders, and congenital high myopia. We measure the horizontal visible corneal diameter from white to white. It's important to know some figures. The normal measurement is about 10 mm at birth. Abnormal values are more than 11 mm in newborn, more than 12 mm in a child less than 1 year of age, and more than 13 mm at any age. Corneal striae are almost pathognomonic. So hub striae are concentric to the limbus in periphery, and they're more typically horizontal centrally near or across the visual axis. The breaks in the Descemet's membrane due to forceps injury can sometimes mimic these lines, but these are vertical, unilateral, central, and the child has normal corneal diameter, and often they have periocular bruising due to the forceps injury. Gonioscopy, we know that the normal angle development occurs by the posterior sliding of the ciliary body from the Sholby line from the 5th month to the scleral spur, that's 5th month to the 9th month. And in the normal newborn eye, the iris has recessed beyond the scleral spur, so the scleral spur is visible only as a whitish band. But in contrast, in PCG, the iris insertion is higher, the peripheral iris inserts to the trabecular meshwork, and the scleral spur is not visualized. The optic disc and the fundus should be assessed. So in the optic disc, we have to note the cupping and the focal areas of rim loss. A cup disc ratio of more than 0.3 in an infant and more than 0.5 in an older child is suspicious. Striking reversal of cupping may result with IOP reduction after successful glaucoma surgery, unlike in adults. And in the retina, we should do an indirect ophthalmoscopy to rule out choroidal hemangioma, pigmentary retinopathy. So these are some of the other causes that can present as childhood glaucoma. So pachymetry is probably not as important as in adult glaucoma, but we know that it can influence the accuracy of the Goldman applanation tonometry. It can artificially overestimate or underestimate the true IOP, but the definitive role of pachymetry in the evaluation of childhood glaucoma is uncertain. So approximately it's 540 micrometer at 6 to 23 months, thinner in primary congenital glaucoma, thicker in aniridia and glaucoma following cataract surgery. The CGRN recommends that CCT should not be used to adjust an IOP measurement, but rather taken into consideration in the overall context. B-scan is an extremely useful tool when we do not have a proper view of the posterior segment. So it can detect marked disc cupping in the presence of opaque ocular media. It can also help us to exclude posterior segment pathology like retinoblastoma or choroidal hemangioma, and it helps us to diagnose and follow up postoperative complications like choroidal detachment and suprachoroidal hemorrhage. Also, increase in the axial length on sequential examination is a sensitive indicator of the progression of glaucoma. UBM, when it is available, can be used in certain situations. So we know UBM uses a frequency of about 50 megahertz with shorter wavelength and shallow penetration causing maximum resolution. It's useful for suspected retroidal pathology, example ciliary body masses. Also useful for assessing anterior segment in presence of corneal edema, corneal scar, dense cataract, etc. So to summarize, primary congenital glaucoma is the most common form of developmental glaucoma. It is isolated, non-syndromic maldevelopment of the trabecular meshwork with no other ocular anomaly. It's usually inherited in an autosomal recessive manner. In the history, we have to know the family history, any consanguineous marriage, and the age of onset of symptoms. The classical triad of symptoms, as we all know, in addition to the classical triad of symptoms, we have large eyes and hazy cornea. These are the more common symptoms in the Indian subcontinent. The diagnosis is mainly established by EUA, so the IOP is measured by Perkins. We have to note the corneal diameter, corneal haze, Hub's strike, gonioscopy, disc cupping, and fundus. USG scan is a useful tool. We have to beware of mimickers, and I think Dr. Murli will take up this topic. And the key message is that prompt diagnosis and proper and prompt treatment can minimize the degree of visual impairment. Thank you. So these are all my key references.
Thank you, Debasis, for an excellent presentation on the topic. I am sure there will be some question which we'll discuss at the end of all presentations.